Alrighty. Dr. Peterson, can you confirm that you can both hear me and see my slides?
We can see you and we can see your
Perfect.
slides and we can hear you. It's awesome.
Love when it all works out. Okay, now I have lost my polling bar. Give me just one moment. All right, got it back up. Hello, everybody. I am Kathryn Veazey. I work with Dr. Peterson and Dr. Frank, and I trained at the same institution as Dr. Meyer. I'm an assistant professor in anatomical science at Drexel University College of Medicine. I am originally from Colorado, so Colorado Springs. I did my training in Jackson, Mississippi, and I absolutely love all the anatomies. So happy today to talk to you about lots of kinds of anatomy. When I'm not teaching, I read a lot of books, I play a lot of tabletop role-playing games, and I actually play with my three rats who are in this ginormous setup right behind me, so hopefully they don't make too much noise. Without further ado, let's talk a little bit about the urinary and the reproductive systems. So starting off, we have several objectives we're going to be covering today. We're going to start off with the bladder, talking about the way that it is innervated. We're going to move on to the pelvic floor muscles, their components and their main functions. We're going to go into just a little bit of histology, talking about the regions of the kidney, differentiating cortex versus medulla, and their structure-function relationships. We're going to go into the changes of the ovarian cycle, what we can see happening with the oocyte and the follicle that surrounds it, as well as what's going on with the uterus related to them. We're going to talk about spermatogenesis and the seminiferous tubule, and then we're going to wrap it all up with a little bit of embryology, talking about how we form external genitalia. So first things first, I've got our first polling question. Ooh. All right, now I have our first polling question. And I'll give you just about a minute to answer this. I see that almost everyone's participated, just in a few seconds. Okie dokie. So we're actually almost a perfect three-way split. So it's good that we're talking about this. So the question is asking us, somebody is feeling like they need to urinate. So we are ready to go to the bathroom, sit down and relax. So we want to know who is actually contracting the muscle of the bladder. The bladder muscle itself is called the detrusor. The detrusor muscle is a sort of pouch-like muscle. It's going to squeeze, and that is going to receive parasympathetic innervation. Remember, the parasympathetic nervous system is our rest and digest system. And so when we are in a space that we feel is safe and comfortable, we are hopefully resting. That is when we're going to want to facilitate something like urination or the micturition reflex. So the parasympathetic nerves are going to help us actually contract or squeeze that little balloon, that detrusor, to allow the urine to flow. When we are not resting, when we are in a more active state, like for example, we're sitting in a classroom learning, we do not want our bladder to be contracting, we want it to relax. And so those are going to be facilitated by the sympathetic nervous system, which is our fight or flight system. We do have some somatic motor innervation, and that's actually going to be to the sphincter that is going to be allowing us to open it up to allow that flow of urine from the bladder. So it's not actually innervating the bladder, it's innervating the musculature just distal or inferior to the bladder. And last but not least, visceral sensories, which nobody guessed. Good job. Those are just telling us that it's time to pee, that the bladder is full. So if we look at all of this together, we can see here, just so we're nice and compared, we've got over here male phenotype as well as female phenotype. You can see both have this bladder. The bladder, again, is a very large pouch shape. It has a thick wall of muscle, which is that detrusor muscle. And on the inside, we are lined with this sort of invaginated, folded membrane. These are called rugae. We have them in lots of expansile organs, so things like your stomach, which also fills and contracts. We have a special area called the trigone, which is triangular. That is smooth. It doesn't have any rugae, and that allows it to sense filling really, really, really acutely because it's not having those folds. It can just feel when it's being stretched. So if I want not to micturate, what I want to do is make sure my sphincters, which are skeletal muscle, we can see the external sphincters right here, those need to stay closed while the bladder needs to relax. So I'm going to have sympathetic activate the detrusor so it relaxes. And I'm going to have the pudendal nerve, which is somatic, not activated. I want it to be relaxed. When I am ready to pee, I'm going to contract my detrusor muscle. So those are the parasympathetics. They squeeze, and then I relax the pudendal nerve. My pudendal nerve allows that sphincter to open, so I am both squeezing from the top and opening from the bottom. Alrighty, let's go to another polling question. And I didn't mention at the beginning, but at any point, if you've got questions, feel free to just put them in the chat. We'll have time at the end, and I'll make sure to go through them. I'll also hang around in case there's a few I don't get to, make sure that those answers get in the chat as well. All right, most of you have your answers in. I'm going to give you just another few seconds. Alrighty, I believe I have everybody. Let's go ahead and talk about it. So the majority of people here are going to say A, the coccygeus muscle. Well, we've got pretty even split then between C and D, fewer people guessing on B. So let's talk about this. So we specifically want to know who maintains fecal continence. Fecal continence is the ability to stop defecation. So we've already talked about urination, releasing pee. This is fecal continence, which is keeping in the poop. So when we're ready, so we can defecate, we're actually going to pass that solid waste through. So we want to know which of these is most closely associated with the openings that will facilitate that, which is specifically going to be things like the rectum and the anus. So I'm going to look for anything that's got rectum or anus in it. In that case, that's going to take me to D. That is the puborectalis muscle. So this is one of your three parts of your levator ani muscle. The levator ani and coccygeus together are the two main components of your pelvic diaphragm. We're going to talk about them in just a second. This is the one that stays tonically contracted. It actually forms a U-shaped sling that keeps the recto-anal junction at an incredibly sharp angle. So we can see here, this is a sagittal view. So we're looking at someone as if they were cut in half, and then we're looking inside. And so anterior is over here, posterior is just behind. You can see the vertebral column. When we have this muscle in its contracted state, so for example, when we're just sitting down or standing, moving around regularly, we keep this really tightly pulled. So we do not want this to be open because that will allow waste to pass through. When we are ready to defecate, once again, we're going to relax this muscle, and that lets this angle get very, very, very broad. Here we can see an inferior view looking up into the pelvic cavity. So you can see here the anal aperture as well as the urogenital hiatus. The amount of orifices present there are going to be based on pelvic sex. So you might have a vagina, it might just be a urethra, depending on what you've got. But we can see again this U-shaped sling or hammock, that's puborectalis. And then just next to it, we have the other two components of the levator ani. Meanwhile, coccygeus, all the way back here, it actually has no direct attachments to the rectum or the anus. So it's not going to be as involved in fecal continence. It is, however, going to help us support all that pelvic viscera. Alrighty, moving away from gross anatomy and into histology. Here is our first question, talking about the kidney. All right, almost everybody's guessed. Gonna give it just another few seconds. I'm gonna close the poll in 3, 2, 1. Okay, vast majority here saying D, with a good proportion of people also saying B. So let's discuss. Here we can see an illustration of a nephron. And so we've also got the vascular component of it as well as the collecting component of it. So really we've got a full uriniferous tubule. But if we look at these components as we move our way from the beginning of it, so in something like the renal corpuscle, we go out through that proximal convoluted tubule, through our proximal straight or the thick descending limb of Henle, into the thin limb, up through the thick ascending limb of Henle, or the distal straight tubule, out through distal convoluted and down into the collecting system. You can effectively draw a line down here once we're past these thick limbs that separates the renal cortex, which is the outer component, from the renal medulla, which is the inner component. And so that tells us that these thick tubes are going to be more in the cortex, while my thin tubes and my collecting ducts, those are down in my medulla. And so we can see that D here is in fact the correct answer. Most of you doing a very good job getting that. Those who answered B, this proximal convoluted tubule, that does go it goes a bit far down. However, we're not going to find it in the innermost layer of the medulla. We're actually going to see that in the outer part of the medulla, as it acts as a really nice transition zone for us between the cortex and the medulla itself. Most of your convoluted tubules are going to be located up in the cortex. Those thick straight tubules are in the outer medulla, and then the thin tube, which is just the loop of Henle, that's going to be inner medulla. So if we actually look at some of this, the differences between the renal cortex and the renal medulla, cortex, as we said, sort of the outer area, it's got two main components. We've got the cortical labyrinth, named labyrinth because it's got all these proximal and distal convoluted tubules. And convoluted tubules, when you cut them, often are going to be cut in cross section. So they look very, very, very squiggly. They're super tightly packed, and they are packed around our glomeruli, which are a really nice way of telling that we are outside in the cortical level. We don't have any glomeruli down in the medulla, whether that's the outer part or the inner part. Separating our cortical labyrinths from one another, we'll have these nice straight rays. Those are called medullary rays. These contain those thick, straight tubules, and they are helping us convey all of that fluid down from the cortex into the medulla. As we move into the medulla itself, we are going to see, once again, there's two main parts. We've got this outer medulla. The outer medulla has a bunch of these thick tubes. You'll actually know that pretty much all of the tubes are thick tubes. They don't have any thin tubes. Versus if we get down here into the innermost medulla, now all we've really got going on is some combination of thin tubes and collecting ducts. It is worth noting there are two parts of the outer medulla. You can have a combination of thick and thin. That's actually called the inner stripe of the medulla. So the big key thing is if you see any thin limbs, any of the simple squamous loops of Henle, you're going to be looking specifically at just somewhere in the innermost medulla. You're not on the outside. Functionally, this is going to help us with something called countercurrent exchange. This allows us to move things back and forth, versus the cortex is really just helping us with the very beginnings of the absorption process and then moving into the secretory process. So we really want to get a lot of stuff out of those glomerular capillaries into our ultrafiltrate, and then we want to concentrate that down in the medulla. Then we go back up to put it into the collecting system.
Dr. Veazey, it's Dr. Peterson.
Yes.
There's two questions in the chat that maybe, especially the last one that came in from Rijab, maybe if you could just take a look at the chat. Is the collecting duct a structure which moves down into the medulla? I think at this point it would be really great if you just took a minute to answer that on the recording.
Absolutely. So the collecting duct is a structure. It is actually the only structure that traverses the entire length of a kidney. So you can find it all the way out here in the cortex, and then it actually goes all the way down through the outer medulla to the inner medulla and then into this area. I'm not sure if you all know the name of this, but basically it goes to the renal papilla, which is where we're going to empty everything out into the calyx system. So we can see the collecting system right here, starting all the way up in the cortex and then traveling through every single layer. So collecting ducts are not helpful to figure out what region you're in, but they are a nice structure. You can see them pretty much everywhere. So very good question. So yes, it does move all the way down. And then let me look, well, is the floor of a structure defined? I'm not quite sure what the first question's asking, so I'll come back to that during the open Q&A time, just for the sake of time. Alrighty, so moving on from the renal system, My poll has disappeared again, so let me pull it back up. All right, you can see this one's a little harder. I'm going to give you another few seconds because I'd love to see everybody get an answer in. I'm going to close in 3, 2, 1. All righty. So we've got a pretty, not quite even, but very close split between B and C. We do have at least one guess for A. So let's talk about it. Before I move into the answer slide, I just want to get us oriented with what this picture is showing. So here we can see, actually starting over at 1, this is going to be showing us a lot of the ovarian cycle or the follicular cycle, which is separate from the uterine cycle. We'll see both of them compared on the next slide. So we start with things like a primordial follicle. They haven't really developed yet. And then they start to mature until we have a dominant follicle. That follicle will then ovulate, which we can see here happening at 4. The oocyte and some of the cells around it will actually go into the uterine tube, while the rest of the follicle that was surrounding it, that becomes the corpus luteum, which we can see here represented in yellow, yellow for luteum, which will eventually degenerate into something like the corpus albicans. So ovulation is the midpoint of our cycle, typically happens around day 14, and that is going to mark the transition between the proliferative phase and the secretory phase. So the proliferative phase is when we are getting ready for ovulation. So we are making a whole bunch of new stuff in the uterus. We're going to see some of those in just a second, but we basically have this massive hypertrophy of glandular tissue. We've got some blood vessels start to build up, and then those don't really become functional until ovulation happens. That is when we enter the secretory phase, which is when those glands become even larger and they start releasing fluid. It's a very glycogen-rich fluid to help nourish any potential embryo that might wind up implanting in it later. If implantation does not happen, then we're going to exit the secretory phase. All of those glands and blood vessels that we just built, they're going to slough off, and that takes us into the menstrual phase. And then the whole cycle picks back up at proliferative. So here we've got a chart showing all of this. We really start everything on the menstrual phase itself, which seems a little bit backwards. But this is because once we're done with the secretory, we no longer have a corpus luteum. Again, it's become this corpus albicans. It's not making a bunch of hormones anymore, and we're going to reset. So when we reset, that's day 1. That's when the menstrual cycle occurs. So we can see that they are linked, this ovarian cycle and the uterine cycle. As the oocyte within the ovary starts to develop and mature and we pick 1, we are building the wall of this uterus. When ovulation happens, we then make that a functional uterus. So again, those glands actually start secreting. That's why it goes from the proliferative, they're just building it, to secretory, they're actually secreting, they're actually functional. For the ovarian cycle, we call this the follicular phase, when we've got a follicle, a shell of cells around the oocyte, which is distinguished from the luteal phase, when that follicle really becomes its own new structure within the ovary, which is that big yellow tissue, the corpus luteum. We can see there's a variety of hormones that help regulate this process, with really the big 2 being FSH, follicle stimulating hormone. It stimulates the follicle, so we build bigger follicles, so folliculogenesis, which allows us to go into this mature follicle state. We also have luteinizing hormone. Luteinizing hormone helps the follicle become luteum. That's why it's luteinizing. So you get something called the LH surge. It gets a huge spike, and that tells the mature follicle it's time to ovulate and the rest of the follicular cells to become the corpus luteum. And that is that process. Here we can see just briefly, we've got the proliferative phase. So again, we're starting to build things. We can see there's a pretty good thick wall. This is the uterus. We can see it in all three parts. We are going to have the actual endometrium. This is the part that does all the fun stuff. And then most of the rest of the uterus is going to be myometrium. It's just a whole bunch of smooth muscle because it's got to contract. So in the proliferative phase, you do have lumen for these glands, but they're not super well developed. We're just now starting to build them. Versus in the secretory phase, the lumen are super well defined. They often form what we call sawtoothed glands, so they're very squiggly. We can see a lot of examples of that here. And this is because we're actually starting to secrete things. So we need large glands with big lumens to allow us to get that fluid out. And then in the menstrual phase, we do not have pregnancy, we don't have implantation, and so we're going to reset all this work. We're going to slough off this functional layer, and we're going to leave a basal layer behind so that we can start the process over. I do see a question in the chat. Does GnRH cause growth of these follicles? An excellent question. It's really complicated. So GnRH, which is gonadotropin releasing hormone, is going to stimulate, so that first of all, that's coming from your hypothalamus. And so that's going to stimulate cells of your pituitary to actually release the FSH and the LH. Those hormones then act on the ovary, as well as a little bit on the uterus, but mostly on the ovary, to cause the oocyte to develop and the follicle around it to develop. So in an indirect way, yes, the GnRH is what regulates the hormones that cause that follicle maturation, but it's not directly acting on them. But it's a very good question, very complicated. Is this a hormone cascade? Absolutely. This is an excellent example of a hormone cascade. So this is one of the axes. So we have a lot of hormonal axes. So a hormonal axis basically is the hypothalamus tells the pituitary to do something, and your pituitary tells somebody else to do something. So in this case, this is your hypothalamo pituitary ovarian axis. All very good questions. Hormones are great, and we can talk about them more in the Q&A session. But for now, I'm going to put a new poll question up, excuse me. All right, I see almost everyone's got their answer in. I'm going to give it just another few seconds. Okay, I believe I have everybody. So once again, not quite 50-50, but pretty well split here between both A and D, with some people guessing B. So let's talk about it. So we're asking specifically, what is the first cell of spermatogenesis? And that is going to be our friend, the spermatogonium. So spermatogonia, similar to oogonia, the gonia is the basically kind of progenitor cell. So initially, we've got what's called a bipotential gonad or an undifferentiated gonad, and it's got all these little bitty cells in it that need to become something. The very first thing they're going to do is either form an oogonium, which can do oogenesis, or a spermatogonium, which can do spermatogenesis. They don't actually start doing much of anything in male fetuses, really male people, until those boys actually enter puberty. Then those spermatogonia, which have just been sitting around doing not very much, actually start to undergo the process of spermatogenesis. So some of them will act as stem cells and just replenish the amount of spermatogonia that are present, while some of them will actually become primary spermatocytes. So those are the second stage of spermatogenesis. Your primary spermatocyte will then undergo meiosis. It is the first cell to undergo meiosis in this lineage, and that creates a secondary spermatocyte. That secondary spermatocyte will continue doing meiosis to form what's called a spermatid. And then that spermatid does some pretty cool stuff, which is called spermiogenesis, which is different, which is where it changes its shape to become a functional sperm cell or a spermatozoon. So let's look at this histologically. So here we can see a graphic that's showing all of these steps. So the spermatogonium is our very first cell. And again, it's got two options. It's going to mitotically divide regardless, but some of those cells will just replenish the spermatogonium pool, while some of them will actually differentiate into primary spermatocytes. And we can see here, this is a cross-section of a seminiferous tubule, which is where we find spermatogenic cells, as well as their support cells, which are called Sertoli cells. Sertoli cells, you can see a really good one right here. They're sort of tall, pale. They've got a central little dot, which is their nucleolus. We're going to talk about them on the next slide. But hanging out on the very bottom, all these little cells that look like they're doing nothing, these are spermatogonia. You can see they're right along that outermost membrane where we separate the tubule from other tubules. As we start moving a little closer to the lumen, we see our primary spermatocytes. Primary spermatocytes are big. They're very large, fairly light, because they're dividing, right? They've duplicated a whole bunch of DNA, and now they got to split it all up. So they're huge. Secondary spermatocytes, you typically don't see them. They only exist for a very brief moment in time, and so we just don't pick them up very well when we try to look at them histologically. But they do exist. They are similar to the primary spermatocyte, a haploid cell, so they've got half the amount of DNA. However, they still have two sister chromatids, which is what allows us to divide even further to form a spermatid. There's two kinds of spermatids. You've got early spermatids, which are sort of round, pale, very close to the lumen. And then you have late spermatids, which are very, very dark and very, very close to the lumen. Those late spermatids are the ones that are going to go under spermiogenesis to become a mature spermatozoan or spermatozoon. You can say either one. The Sertoli cells, which are another really important part of this tubule, again, you can see them here. They are large, they're pale staining, they hang out between the basal compartment and the adluminal compartment. And the reason they're there is they actually separate those two compartments so that you don't wind up having an immune attack against your own sperm cells, which could be really, really bad. They also produce a ton of hormones. One of these is called anti-Müllerian hormone. That's incredibly important embryologically to help us make sure that the male fetus is forming only male structures and not forming female structures, which are Müllerian structures. So things like the uterine tubes, for example. All right, our last little question here. And I want to make sure I can still see the chat. Okay, perfect. I see about half of you responded. I'm going to give this another few seconds. I'd love to see a few more answers. All right, I'm going to close it in 3, 2, 1. All righty, fabulous. I think we got everybody in. Most people here saying C. We have a couple votes for each of the other options. That is excellent. The answer in this case is going to be C. So we're asking which of these come from the same thing in their indifferent or in their undifferentiated state. And that is going to be the labia majorum and the scrotum, which come from the incredibly conveniently named labioscrotal folds. We can see for each of these other options, we'll walk through them one at a time, and then we'll see a really nice graphic that sort of lays it all out. So labia minora, that's going to come from what's called the urogenital fold, while the glans of the penis is coming from the genital tubercle. So tubercle means sort of protrusion. So both the glans clitoris and the glans penis are coming from that tubercle. We can see that also represented here in B. Down here for D, the penile raphe or raphe, you can say it lots of ways. That is also coming from these urogenital folds, so it is going to be homologous to the labia minora, while majora, as we can see, come from that large labioscrotal fold. So here we can see when it's undifferentiated, We've just got these large zones, which include things like the tubercle, these urethral folds, and the labioscrotal folds just lateral to them. We then typically take one of two pathways, which is we're going to form more masculine structures. So we're going to take our tubercle and we're going to form a penis, but specifically just the most distal part of it, which is the glans of the penis. This is the part that will be associated with the urethral opening. Versus if we go down the female pathway, we're going to turn that into the glans of the clitoris, which is not associated with the urethral opening. We're going to separate them. If we look just inferior to that in this red color, these are those urethral folds. We can see we're actually going to fuse them together in male development. So again, this forms the ventral surface or sort of the underside of the penis, which is called the pharyngeal raphe or raphe, sort of this midline. It's not really a groove, it is just a line. It's a thick ridge of tissue. While we're going to have the labioscrotal fold form things like the scrotum itself. Yes, that's what I'm going to say about that. If we go over here, we leave them open. So we don't actually close it fully. We want to leave this vaginal orifice, and that is where we're going to put the urethral opening. So we can see we have the urethral opening separate from the vaginal opening, and in both we will form an anus, which hopefully is patent and completely separated. This is also heavily regulated by hormones. So testosterone, as well as something it's converted into, which is called DHT, dihydrotestosterone, those are going to push us towards the male development pathway, the male phenotype, while the things like estrogen and the absence of masculinizing hormones or androgens, those are going to push us towards the female phenotype. I see a question. Is C more correct because they're both external? That's a good way of thinking about it. So they are most on the outside. And that should hopefully make sense because they both came from basically the same spot. So we can see we've got externally here and here. These are going to be those labioscrotal swellings. The most outer area in female development is the labia majora, while the outermost area in male development is the scrotum. So that's a very good way of thinking about it. They're most lateral, they are most external. Alrighty, here's all my references. I'm happy to open the floor to additional questions.
Dr. Veazey, it's Dr. Peterson. Until we see some questions coming in the chat, you have a few more minutes, maybe just going over the developmental timeline, like when is this all happening? I think that would kind of put it in perspective for not only the students that are here with us tonight, but also those that are going to watch the video.
Very fair. And I might have you help me out a little with specific weeks, but the first thing people should understand, so incredibly early, as in like week 3, we are going to do what's called sequestration. So we're going to take some very important cells, which are going to help us form these cells, which are going to become gametes. So we're going to sequester those, and those are called PGCs, primordial germ cells. So that's happening when gastrulation is occurring. So I make tissues, and before I make all those tissues definitive, I got to go put my sperm cells away and my oocytes. I got to put the sex cells away so that they don't get all that signaling. And then I'm going to bring those cells back a little bit later. Typically that happens like week 5, 6, and we're going to start building all of these systems together. So again, thinking about this, that's still really early, very, very early. By the time you're getting into week 8, give or take, you've pretty much decided which of these paths you're going to go down. So you start the process of more differentiation, and so you start forming things like the two ductal systems. So you've got things like the mesonephros duct and the paramesonephros duct. You've determined which of those is going to be promoted and which of those is going to be inhibited to regress fully. So by the time you're reaching weeks, I believe 12 to 14, this is where I'll take a perfect. By 12 to 14, give or take, you pretty much have the external genitalia decided as how they're going to be. And at any point along that process, any of these steps can go a little bit awry, and they can cause some differences in sexual development, which are called DSDs, which can create things called atypical genitalia, which is they don't fully fall into one of these categories. And again, that's anywhere between 3 through 14-ish weeks. Dr. Peterson, anything you want to add to that?
No, but I think you did a great job on that. And I'll just reiterate that this is why an ultrasound cannot determine the predetermined male versus female, the sex of a fetus until about 18 weeks. And so keep that all in mind. And then I'm seeing some questions coming into the chat, Dr. Veazey, and I'll take the first
Mhm.
one, which is from Jaden. So for all of you, that are watching this or in real time, but the PowerPoint slides as well as the recording will be posted sometime tomorrow, both in the Google Classroom and on the Anato-Bee YouTube channel. That's where you'll find these recordings. So Jaden, hope that helps you. Dr. Veazey, maybe the other questions, um, we
Yep.
should have you take those on.
Great. So, just because I don't know if the recording will have the chat question, so is the indifferent stage the same as the bipotential stage? Yes, basically. So it just depends on which language you're using. Oftentimes we use bipotential. That is the same as undifferentiated. That is the same as indifferent. All of those can be used interchangeably. Bipotential is the oldest term, so most people still use bipotential. Recently, there's been a shift to use indifferent or undifferentiated because that doesn't just limit it to two. As I've already mentioned, there's actually lots of options we can get with genital development, which is a whole spectrum of things called those DSDs, differences in sexual development. But yes, they're all the same thing. So, does female anatomy have just the labia minora at time of birth? Really great question. So no. So, as we were sort of mentioning, fairly early, so we're talking, first trimester of development, you are already building the full external genital structures that that fetus is going to have. By the time you're getting to birth, you've got the whole system in place. It's all just small, right? It's going to undergo further maturation as the person ages, and especially as they undergo puberty. But in female fetuses, they do have all of these structures present. So they do have the clitoris, which has multiple parts. We really mostly just focus on the glands. We've got the vaginal vestibule, which has the two orifices, so the urethra and the vagina. That is going to be lined immediately by labia minora. And then just external to that, we've got the labia majora. So all structures are present at the time of birth, if development has gone the way it is supposed to.
And then there's a question from Vaish, I hope I'm pronouncing that correctly, which I think is better sort of answered with the presentation that Dr. Frank is going to make. Your question about the floor, how do we determine floor in different organs? And that really, especially, I think you're talking about the interventricular septum between the two ventricles of the heart. I think he's going to make that really, really clear. So I'm going to turn it over. Dr. Veazey, thank you so much for joining us. You did a great job and we're so appreciative. And Dr. Frank, I'll let you go ahead and introduce yourself.
Good evening, everyone. I'm Dr. Bill Frank. I'm back at it with you. This is my third year doing the regional um, anatomy review. And I am also from Drexel University College of Medicine, and I do work with Dr. Peterson and Dr. Veazey at the West Reading campus. So there I teach gross anatomy, histology, and embryology to the first year medical students. So I'm happy to be here with you this evening, and I will be discussing the cardiopulmonary system. So um, I am not going to use the um, usual polling. I would like to actually hear voices if I could, um, and ask you just some kind of off the cuff questions if I could. And uh, you can also put answers or questions in the chat, try to get to them as I can. So one of the things I want to do is look at just a general overview of the heart and lung functions. We know that the heart works as an integrated cardiopulmonary system. to oxygenate blood and to circulate it through the body. And we can see that here in this graph. Okay. The heart pumps oxygen poor blood to the lungs, which exchanges carbon dioxide with oxygen, and then that freshly oxygenated blood is returned to the heart, which is then pumped to the tissue. So that's kind of what this graph is showing here. So the right side of the heart is going to become more of the pulmonary system, and the left side of the heart is going to be more of the systemic system. Okay, so what are some of the key functions of the heart? It is a four-chambered pump. It allows for circulation, and it is involved in pressure maintenance. So the left ventricle, because it's going to pump the blood to pretty much the whole body, it is a high pressure, and there's a high force of pressure that goes through the aorta, and which is going to make the aorta a little bit more specialized artery than the other muscular arteries and smaller arteries and capillaries, which we'll talk about. For the lungs, we know that it is mainly involved in gas exchange. It is located in the chest, and allows for inhalation and exhalation during respiration, allowing for the exchange of carbon dioxide for oxygen. We're going to look at alveolar action and these little tiny sacs, which allow for transfer of oxygen into the blood and to remove carbon dioxide from it. And we'll also hint about some of the lining of the different parts of the respiratory system, especially some of the unique features such as the respiratory epithelium, the mucus that it will create as well. So together, these systems are going to work together to create oxygen and release the carbon dioxide from the blood. And so we'll talk about, again, the right side, which is the pulmonary circuit, and the left side, which is the systemic circuit. And remember that the entire cycle is rapid, with the blood traveling through the body in about 16 seconds. So it is very efficient as well. Okay, so the thorax has three compartments. Two are in the left and right side, which are the pleural cavities, and the middle is the mediastinum. And the mediastinum is divided into two main areas, a superior mediastinum and an inferior mediastinum, with the inferior mediastinum also being divided into an anterior, a middle, and a posterior. Okay, so the contents of the mediastinum: in the superior mediastinum, we see the aortic arch and its branches, the superior vena cava and its tributaries, the thymus gland, which will be located anteriorly. We'll see a bunch of nerves coming from both the sympathetic and parasympathetic systems. We'll see the esophagus, which is coming down from the neck, as well as the main lymphatic channel called the thoracic duct, and the phrenic and vagus nerves. In the inferior portion, we'll see in the anterior area the thymus and lymph vessels. We'll see in the middle mediastinum basically the heart, the pericardium, roots of the great vessels. We'll also see the phrenic and the vagus nerves. And in the posterior mediastinum, we'll see the descending aorta, the azygous and hemiazygous veins, again, the thoracic duct, and the esophagus. So can anybody tell me what nerve runs anterior to the root of the lung and innervates the diaphragm? Anyone? You're in the chat, or you can, okay. I think you got that. That is correct, the phrenic nerve. So let's do the opposite. What nerve runs posterior to the root of the lung? It provides parasympathetic innervation to the heart and lungs, and also to the upper portion of the gastrointestinal system. What nerve would that be? All right. We are cooking with peanut oil here. You are absolutely correct. The vagus nerve, the wanderer. Okay, so when we look at the pericardium, we see a serous membrane surrounding the heart and the roots of the great vessels. And this pericardium has two parts. It has an outer fibrous part, which we can see at the very outer part of the uh, mediastinum, and then the serous part, which is the inner part. And there are two parts to that. There is a serous parietal pericardium, which lines the inner part of the fibrous pericardium, and then the serous visceral pericardium, which is intimately associated with the external portion of the heart. So much like the fist pushing into this balloon, we can see that the around the that fist is going to be the visceral serous pericardium. The part lining the outside of the balloon is going to be the serous parietal pericardium, and then the most external part is the fibrous pericardium. So in between all of that is the pleural space or pleural cavity. So can you tell me another name for the serous visceral pericardium? That's great. Yes, it is also called the epicardium. So when we look down here at the cross section, we can see from external to internal. So this is the heart cavity. We'll see the fibrous pericardium. Just internally, it will be the serous parietal pericardium, then the parietal cavity or sac, and then the epicardium or the serous visceral pericardium right next to the myocardium, and the lining on the internal part of the heart is called the endocardium. So the fluid-filled cavity, again, is between the two layers of the serous pericardium, and it has two functions. It cushions the heart and it reduces friction when the heart beats. So I had a question. Does the phrenic and vagus nerves exit in both superior and anterior mediastinum? The phrenic and vagus nerves are located in the superior mediastinum coming down from the neck, and then are located in the lateral parts of the middle mediastinum. Yes, that's a good question. Okay. So we want to talk about two parts of the innervation of the heart. One is the heart conduction system, and then we'll talk about the actual innervation of the heart. So in the heart conduction system, the pacemaker of the heart, the SA node, establishes normal cardiac rhythm, and the SA node is located at the superior part of the right atrium. From there, the SA node will send signals through the wall of the atrium and also over to the left atrium as well, called Bachmann's bundle. And this will cause unified contraction of both chambers, both atria. Okay. That signal will then go down to the AV node, which is still at the base of the right atrium. There, the signal will pass through the cardiac skeleton into the bundle of His, or the AV bundle, into the interventricular septum. There, it will separate into a right and left bundle branch. And at the apex, it will wrap around the wall of the ventricles, and that is called the Purkinje fiber. So we can see that the atria will contract, then the signal being delayed just slightly here at the AV node to allow for atrial contraction, and then the signal will go down through the ventricle, causing ventricular contraction. Okay. Okay. Another concept that we wanted to talk about was anastomoses. the anastomoses are interconnections between different arteries, and we see them all over the place in the body. And this creates a redundancy in blood supply to certain areas that are really important, such as around joints, but also around the brain, around the heart, as we can see here. And this allows for continuous flow of blood, even if some pathways are blocked. So we talked about this in the brain, the circle of Willis, between the posterior circulation and the anterior circulation, between the vertebral arteries and the internal carotid arteries. We also talked about it in the hip between the medial and lateral femoral circumflex arteries that give collateral circulation around the hip. In the heart, we know that there is a right and left coronary artery, and these are going to wrap around the heart into the back of the heart. They're going to provide vascularization to certain parts of the heart, but they're going to overlap as well. We can see there's an overlap in the posterior part of the heart, but also at the apex of the heart. Can anyone tell me which artery is more responsible for vascularization of the apex of the heart? The left anterior descending artery or the right posterior descending artery? Which artery is more responsible? All right. You are right on. The left anterior descending artery is going to be the predominant artery supplying the apex of the heart. Of course, there's variations, and sometimes it's they're equally present, or very infrequently the right anterior descending can be the major supply to the apex of the heart, which makes the left anterior descending even more critical in heart circulation, because if that gets blocked, we're going to have a major part of the heart, the left ventricle and the apex of the heart, damaged, and that's going to cause major problems in the individual. Okay. All right. So we're talking about the mediastinum and the pericardial sac. Let's talk about the pleura, the pleural sac. So the left and right pleural cavities are separated by the mediastinum. And remember, the structures of the mediastinum are everything, the heart and the great vessels and all of the stuff passing down through the neck into the thoracic cavity, and even some of them passing through in the abdominal cavity. So the pleural cavities line both the outer part of the lung and the inner part of the wall of the thorax, and even the diaphragm, the mediastinum, and even the cervical part here has a parietal layer. So the pleural cavities between layers provide fluid to reduce friction during breathing, and it helps lungs to expand and fill with air. So when we look at the pleura, it is very similar to the pericardium in that the lung grows into the pleural sac, and then it develops both a visceral layer and a parietal layer with a cavity in between. And we can see that here between the visceral pleura on the lung and the parietal pleura lining the wall of the thoracic cavity. The lungs are comprised of 2 and 3 lobes. The right lung has 3 lobes and is divided by a horizontal fissure and an oblique fissure. The left lung has 2 lobes and is divided by the oblique fissure. The phrenic nerve supplies innervation to the diaphragm. So the innervation of the lungs are, number one, the parasympathetic system, which is going to constrict bronchi and increase mucus production. Conversely, the sympathetic innervation dilates the bronchi. So think about it. What effects do parasympathetics and sympathetic innervation have on heart rate? So we talked just about the parasympathetics of the lung, but can you tell me what I reviewed? What is the innervation of the heart? The sympathetics do what to the heart rate? Does it increase it or decrease it? Okay, sympathetics are going to increase heart rate. Parasympathetics are going to decrease heart rate. Okay, all right. And the sensory fibers come from the vagus nerve and the sympathetic thoracic ganglia. Very good. Okay, so let's look at the tracheobronchial tree. So if we start here at the top, we see the trachea coming down, and it's going to divide into a right and left primary bronchus. Primaries will split into secondaries. The secondaries will branch into tertiary. From there, we will get the loss of cartilage, and we will now see bronchioles, the conducting bronchioles, and then the respiratory bronchioles. From there, it's going to further divide into alveolar ducts and saccules, and eventually alveoli, which are going to be at the most outer part of the lung next to the visceral pleura. Okay, so at what point does oxygen exchange begin to happen? Does it happen at the conducting bronchioles or at the respiratory bronchioles? Anybody? At the respiratory bronchioles, great. Um, the trachea to the terminal bronchioles are going to be part of the conducting zone. From there, from the respiratory bronchioles to the alveoli are known as the respiratory zone. Very good. Okay, so we're going to shift gears a little bit and get into a little bit of histology, okay, for the cardiovascular and respiratory system. So the histology of artery and veins are similar in that they have three layers or tunics, which make up the walls of arteries and veins. There's an internal part, which is a tunica intima, the tunica media, and then the tunica adventitia or externa, which is the outer portion. And these are going to be classified by size and characteristics. And we can see this very nice chart of the arteries and veins and then the capillaries. I won't go through a whole bunch of this, but I did want to ask, is this considered a large elastic artery or a medium muscular artery? Can anybody tell me? Okay. You are correct, Rashab. It is muscular due to its big internal elastic lamina. So we can see, I always think it looks like a rubber band that's been stretched too much and then it comes back. Okay, so we can see that the artery itself is going to have a much thicker wall, which is more musculature. Usually it's going to be very round in shape versus a vein, which is usually going to be a little bit larger, but very flat and collapsible. So when you see the characteristics here, no matter what size, the arteries usually be more rounded, where the veins will be more flattened. And so I would give it you in charge to look at this chart and study it and look at the difference between the large elastic arteries, which would be like the aorta, versus the medium, which basically many of the named arteries of the body. And then, of course, the large veins, which would be like the superior vena cava, which then the mediums are most of the named veins of the body. So I think this is a really nice chart and would encourage you to review it a little bit to familiarize yourself with the different characteristics of each. Ah, I think you were asking me about a picture of large arteries. So this right here is a large artery. This is the aorta, and we can see the tunica intima here and the very thick tunica media with a lot of elastic fibers with the smooth muscle and the tunica adventitia or externa. So the medium vessel in comparison, we're going to see that in inner elastic, what I call the bunched up rubber band appearance here of the medium-sized artery. We see even a smaller vein and artery. We can see the artery is going to again be circular with a lot of smooth muscle. and the tunica intima here with some elastic fiber where the vein is going to be a bit larger and more collapsible. And then as we get down in, you can see in the adipocytes, we can see the very small capillaries in between the cells. And a little bit larger view, we can see again the arterioles versus the venules. So just different sizes, but the characteristics are very much the same. So you think about where each of these things could be found. Okay. When we look at granulocytes and agranulocytes, we've already talked about erythrocytes a bit previously, but the granulocytes are what we want to look at now. There are basically two different types of white blood cells, granulocytes, which are going to have colored granules on specific staining, which are going to be neutrophils, basophils, and eosinophils, and agranulocytes, which you're not going to be able to see the granules, and those are going to be lymphocytes and monocytes. And we can see here that granulocytes have different functions. I would encourage you to familiarize yourself with each of these functions for each of the types of granulocytes and monocytes. Okay. Okay. And just to go over real quick the characteristics, the granulocytes. First, we're going to see with the specific right staining, we're going to see bilobed nuclei, smooth outline with cytoplasm with large eosinophilic granules. So this is the eosinophils. Conversely, the basophils are going to have the basic staining granules, and they're going to have more prominent basophilic granules, but also bilobed nucleus. The most numerous of the granulocytes is going to be the neutrophils, and these are very characteristic of having multi-lobed nuclei with thin bands in between, and it looks almost like a pearl necklace type of thing. It has a clear cytoplasm because the granules are at or below the microscopic level, so these are neutrophils. The agranulocytes are going to have more of uh, a center nucleus. The monocyte is going to be a kidney or horseshoe-shaped nucleus with irregular staining cytoplasm, and the smaller rounded nucleus of the lymphocyte with just a rim of cytoplasm around it. So if you think about what are the functions of these different kinds of granulocytes and agranulocytes. Okay, so I have a little mnemonic that I use to remember the percentages of these granulocytes and agranulocytes in the bloodstream, and that's called never let monkeys eat bananas. So neutrophils, lymphocytes, monocytes, eosinophils, and basophils. So neutrophils are 60%, lymphocytes are 30%, monocytes are 6%, eosinophils 3%, and basophils less than 1%. So if you think of it 60, 30, 6, 3, 1, and that'll be neutrophils, lymphocytes, monocytes, eosinophils, and basophils. Okay. So going through the histology of the respiratory pathways between the conducting air system and the respiratory or gas exchange system, we'll see different characteristics from trachea to small bronchi to terminal bronchioles, respiratory bronchioles, alveolar ducts, and alveoli. And the main thing I want to point out here with the trachea and small bronchi are that they are lined with pseudostratified columnar ciliated epithelium. They're going to have mucus glands present. Uh, they will have cartilage. We can see the hyaline cartilage here. Okay. And they will have some smooth muscle. Okay. As we get down to the terminal bronchioles, we lose the mucus cells in the glands, and we're also losing the cartilage. So we can see a very vast difference between trachea and small bronchi versus the terminal bronchial and alveoli. We can see that there will be a change between smooth muscle and also with the types of epithelium. So again, I would familiarize yourself uh, with this chart and understanding the differences in both epithelium type, the presence of cartilage or no cartilage, the presence of glands between the trachea all the way down to the alveoli. Yes, goblet cells are mucus cells. That's a good question.
And Dr. Frank, if I might, if I could, there's been another couple of questions in the chat. So just so that's on the recording, again, not always with these different white blood cells. We give you some characteristics of the shape of the nuclei. Sometimes you can't see the nuclei. Sometimes based on the plane of section, they don't really appear in the way that we've described them. But for the regional competition, we will give you classic examples of that. And then coming back to the question about mucus. So goblet cells are mucus producing glands, but they're single or what we call unilobular, or so they're a single cell producing mucus. That's different than other glands that are mucus producing that we have throughout the body. And I think maybe Dr. Meyer might be talking about some mucus producing glands in the stomach. We have different mucus producing glands in the neck associated with salivary glands. So just keep in mind that yes, goblet cells are mucus producing, but they're single cells that are producing mucus, and that's really important to understand.
Thank you. Okay, so histologically, we can see the lining of the trachea with the pseudo uh, columnar epithelium. We will have the cilia and goblet cells here. We can see this in cross section here as well. We're seeing this is coming from the trachea now to more of the secondary bronchioles because the hyaline cartilage is broken up. We can see that here. We can see hyaline cartilage, can see the bronchial glands, and also smooth muscle in the adventitia. So as we get down again to the later part, we can see the terminal bronchioles transitioning into the respiratory bronchioles. Terminal bronchioles still are very contiguous. As we get down to the respiratory bronchioles, they start to become scalloped. And we can see that here, they're not quite nice and linear. And we see that they start to break up. That's where the respiratory bronchioles start to form. And then from there, we will see the alveolar ducts. And then we'll continue on here again as the terminal bronchial. We're seeing the alveolar ducts here. And then those are going to start going into the alveolar sacs and then into a alveolus. And we can see that in section here of the alveolar sac area and then the alveolus itself. Okay, and we can see that they're lined with type 1 and type 2 pneumocytes. Can anybody tell me which of those two are responsible for producing all of the forms of the surfactant used to keep the alveoli open? That is right. Boy, you guys are on it tonight. Type 2 pneumocytes. Very, very good. Okay, so the last portion here, the embryology. We know that the heart develops early in the third week from the cardiogenic field, which is in the splanchnic mesoderm, in the embryo's cranial region, which we talked about in that trilaminar disc. Precursor cells form two endocardial tubes that will fuse into a single beating primitive heart tube by day 22. And this tube will then undergo a complex looping from day 23 to 28 and septation by week 8, incorporating cells from first and second heart fields to form the four-chambered heart. Okay. And again, we had a question about the interventricular septum, and we can see the interventricular septum here, which is going to rise up from the floor of that primitive heart tube and merge with the endocardial cushions that are coming along that are going to eventually separate the atrium from the ventricle. So there are some holes that and bypasses that are um, in the fetal circulatory system that help with shunting blood from the right side of the system to the left side of the system. Because remember, we're receiving the oxygenated blood from the mother. So the blood does not need to go to the lungs yet to become oxygenated. They're already oxygenated, so we can just kind of bypass that for the most part. So the three areas are going to be the foraminal valve, which is going to be an opening between the right and left atrium, which is going to allow blood to flow from the right to the left side of the heart so that it can go into systemic circulation. Okay, this shunt closes when the atrial pressure increases at birth, and it will end as the fossa ovalis. The ductus arteriosus is a connection between the aorta and the pulmonary trunk, and it again allows the right-sided heart blood from the right side of the heart to transfer into the left system and into the aorta and to the body, again, because we don't need to send all of that blood to the lungs. So again, at birth, this is going to close and it will form the ligamentum arteriosum. And the last one is the ductus venosus, and this is branches from the umbilical vein that allow for oxygenated blood in the placenta to go to the heart, bypassing the liver. So there's another bypass in the liver. Instead of going up through the liver, it just goes into the liver and into the inferior vena cava. So this allows the blood to pass through and then go into the right side of the heart, which then again can shunt into the left side through the foraminal valve and the ductus arteriosus. And this closes slowly during infancy, so this takes a little longer to close. And eventually in the liver, we'll see that as a ligamentum venosum. Okay. So we talked a little bit about the airway system, but the lung bud forms from a bulge from the foregut in the endoderm. And this is the beginning of the separation between the trachea and the esophagus. So that septum forms between the trachea and esophagus, which allows the laryngotracheal buds to form and start extending. And from there, the right and left bronchi will then form, followed by secondary bronchi, which then will form into tertiary bronchi. And these will then further divide into alveolar ducts. And eventually they will form terminal sacs, which will be in close contact with the capillaries and will eventually form the mature alveoli. So we can see the stages here. The embryonic stage at 4 to 7 weeks versus a pseudoglandular stage is going to be at from week 5 to 17, which is going to form the bronchioles. And then the canalicular stage is where we start to see the alveolar sacs develop and the arteries approximating the alveolar sacs, but they're not quite there yet. At the saccular stage, we see that accentuate or approximate even more. And it is at this time that the air exchange could start to happen. We know that the process of developing this oxygen exchange happens even into from 36 weeks even to 21 years. So even after you're born, we're still developing those connections between the arterial system and the alveolar sacs. So at what point does the exchange of oxygen begin in the respiratory tree? Is it at the bronchioles, conducting bronchioles, or respiratory bronchioles? Okay, very good. Okay, so lastly, the lung embryology. If this budding does not happen correctly, we can get what are called tracheoesophageal defects. And this is an incorrect partitioning of the esophagus and trachea, which can lead to esophageal atresia, or blind pocket, or it can actually result in tracheoesophageal fistulas. And we can see several different forms here. So the tracheoesophageal fistula can include very severe respiratory distress, choking, cyanosis during feeding, aspiration of food and saliva into the lungs, and it requires immediate surgical intervention to prevent pneumonia, long-term swallowing difficulties, and in some cases, severe abdominal distension. So insufficient surfactant, which allows for inflation of the alveoli, and it does so by increasing surface tension. If we do not have enough surfactant, it will result in a collapse of the alveoli during expiration. So this can lead to respiratory distress syndrome. So babies born prior to 28 weeks will often not be able to breathe on their own because they do not have sufficient surfactant to keep the alveoli from collapsing. So artificial surfactant can be administered and must be done so within 15 to 30 minutes to 2 hours of life in order to allow for oxygen exchange to occur. So again, what cell type was responsible for creating surfactant in the chat? All right, we got it. Type 2. Okay, all right. And here are my references.
Dr. Frank, that was fabulous. Thank you so much for taking us through both the cardiovascular and the pulmonary systems, from the anatomy to the histology to the embryology. We so appreciate this. And again, just a reminder that although there are not that many joining us in real time tonight, we usually get somewhere between 250 and 300 hits on the YouTube videos once they're posted. So, this is all making a huge difference in the preparation for students that are moving on to the regional competition. So at this point, I would love to have Dr. Meyer come on and introduce himself. And our final segment for the tutoring session tonight will be the GI tract. So Dr. Meyer, please, if you'd like to tell us a little bit about your background and maybe a fun fact, and then we'll go ahead and have you start sharing your slides.
Okay, thank you, Dr. Peterson. I am in a strange view, so.
This meeting is being recorded.
You're fine. Take as much time as you need.
All right, can y'all see me okay?
We can.
All right. All right, and then what I'm also going to try to do is keep my chat open on my phone so I can follow along with students' responses. All right, well, welcome everyone. My name is Edgar Meyer. I serve as an assistant professor at the University of Mississippi Medical Center in Jackson, Mississippi. And there I teach pretty much all the disciplines of anatomy, from histology, embryology, gross anatomy, and neuroanatomy, mainly to medical and graduate students, but I also teach dental students as well. So in this particular session, we're going to touch on a number of these learning objectives. There might be a few that we don't necessarily quite get to, But if there's some time at the end and there are some additional questions that you have, I'll be happy to answer those. And so how I've done this is I've organized some of this content around specific medical cases that will help hopefully engage you and incite your interest as we explore the specific content. Okay, we'll start out with just a basic question here. Which of the following organs are comprised of muscles under volitional control and performing its function?
Dr. Meyer, we're still not seeing your slides. Can you make
Oh.
sure that you're sharing your slides with all of the students?
Here we go. All right. Okay, can y'all see my screen now?
We can. Thank you so much.
Perfect. All right, sorry about that. Okay, I'll give y'all a few minutes to answer this question.
And you wanted them just to put it in the chat. Is that correct, Dr. Meyer?
Yes. Okay, yeah, I'm seeing some. Yeah, great. All right, D. Yes, so the correct answer is pharynx, because that is the part of the alimentary canal that has the skeletal muscles that are under voluntary control. And so just to take a little time to share a particular story and to kind of hit home on the emphasis and importance of sharing stories and the power of sharing stories. If you can, take a moment maybe to think of your closest friends. So those that you spend quite a deal of time with. Maybe there are friends that you regularly share meals together with. And since we're talking about the digestive system, that might be very apt and appropriate to think of. But just keep in mind those friends that you treasure, that are meaningful to you in your life, and that really make your day-to-day experiences more enjoyable. And, you know, the friends that I think of in particular, one who recently passed away, his name is Tim Shanks. And how many of you have heard of the disease known as ALS, or amyotrophic lateral sclerosis, also known as Lou Gehrig's disease? Yeah. And so it's really a terrible disease. I'm hoping that maybe in the future there will be a cure for the disease. But in the last moments of people's lives that suffer from the disease, they usually have to deal with things like dysphagia, so the inability to swallow and use those volitional muscles that control our pharynx. And then sometimes even worse, there's an asphyxiation that can occur where the individuals are no longer able to breathe on their own. And by not being able to swallow, they might asphyxiate on their own saliva. So it's a very, very terrible disease. But another story, a professor of mine, again, who passed away several years ago, also suffered from the disease. And he had this great mentality of every time you asked him how his day was going, he would always say, living the dream. And I always think back to his mentality on life, that even if there were frustrating things occurring or things weren't necessarily always going his way, he always had this positive outlook, and would always comment living the dream. And so now I have found myself, every time somebody asks me how my day is going, I always respond with that living the dream comment. But back to the pharynx, I pulled up two images here. One is in a sagittal view that we see here from the side. And then we have one here from a posterior view that has our skin and a number of our deep back muscles removed, so that you can see some of these pharyngeal muscles. And for the sake of this content, you're not expected to know the names of each of these individual muscles, but what you can be familiar with for now is that in this sagittal view, for instance, we can see our three constrictor muscles, also known as circular muscles, that sort of wrap around and have these kind of horizontal, like horizontal range fibers as they grip some of these cartilaginous and bony structures to form the posterior wall of our pharynx. In addition, you will see these longitudinal pharyngeal muscles. Here is one here. Here is it in another view posteriorly, and then here is another longitudinal pharyngeal muscle. And so we have three sets of each, and each of these allow us to swallow. Our longitudinal muscles will help elevate our pharynx, pull it over the food that we're swallowing, and our constrictor muscles will help push food down, the bolus of food down in a sequential order. All right, so now that we've talked about this first organ or structure in our GI tract, we're going to move to an overview of our GI tract. And if we think about our mouth or our oral cavity, we of course have an opening, and that would be known as the oral fissure, or a more fancy term in Latin would be the rima oris. Following our oral cavity, just posterior to it, we have the oropharynx. And then as we descend, we move into our laryngopharynx. And as you all will know, the epiglottis, when closing, blocks the airway into our larynx, so that any food or liquid that we swallow will pass on into the esophagus and not the trachea. We have three parts of our esophagus. And if y'all in the chat could let me know, populate what those three parts of the esophagus are. And these are kind of like generic names or terms. Okay, cool. Cervical, thoracic, abdominal. If we're breaking it up into numerical parts, how do we typically break it up, and how, or in what classification of tissues do we use to separate the different parts? So for example, the proximal 1/3 of the esophagus would be primarily composed of what type of muscle tissue? Yeah, perfect. Skeletal muscle. All right, so the upper esophagus, or that proximal 1/3, mostly skeletal muscle tissue. All right, and how about the middle 1/3 of the esophagus? Okay, so I see some uncertainty, some question marks. So the middle third will actually have a mixture of both skeletal and smooth muscle tissue. So then that would bring us to our distal 1/3 or lower esophagus. Yes, okay, which would have all smooth muscle. Okay, as we descend through our esophagus, go through the diaphragm, we will enter our stomach. Our stomach has 4 parts, and who can name the 4 parts of the stomach? Okay, yes. All right, so we have the fundus, which is the little bump here, the body, which makes up the majority of the stomach, and I think the head that one respondent put. There's another name for the part of the stomach where the esophagus joins it, and it has to do with what organ just sits superior to that region and the overlying diaphragm. Okay, I'd like yes, so the esophageal sphincter is there because that is where our esophagus joins our stomach. And yes, the cardiac region of the stomach. And it's named that because if we look just superior to it and superior to the diaphragm, we would find the heart resting in that area. And then finally, we have the pylorus as we move into our small intestine. And who can name the 3 parts of our small intestine in order? Yes, of course. All right, so duodenum, jejunum, and ileum. And then sometimes there's a bit of confusion with the large intestine using terms like large intestine, large bowel, which are often synonymous with each other, and colon specifically. So the 5 parts of the colon and the rectum would both collectively comprise our large intestine, but the rectum is actually slightly distinct from our colon, and we might touch on that histology a little later in this session. But what would be our 5 parts of the colon? Okay, so we've got the ascending part, okay, and what comes before the ascending part? Okay, this region here. Got the cecum, ascending colon, okay, transverse colon, descending colon, and sigmoid colon. Okay, and that would conclude our parts of the colon as we move into the rectum. And then finally, we conclude with our anal canal and the actual opening with the sphincter muscles, the anus. I also saw that some people mentioned the flexures in our colon, which are nice to mention. We have our hepatic flexure, also known as the right colic flexure because it's on the right side, and our splenic flexure, also known as the left colic flexure because it's on our left side. All right, so we're going to introduce a case here. She had a lot of fun or not. So we have a patient here, age 63 years. She self-identifies as woman, self-identifies as white. She presents at her GI clinic. Chief complaints include chronic heartburn, acid reflux, chest pain, and difficulty swallowing. This coronal and sagittal view of her chest radiographs, and then the white arrows that we see here actually reveal a hiatal hernia, also known as a diaphragmatic hernia. And so a question related to this case is, what most proximal intraperitoneal organ of the GI tract has herniated through the diaphragm in this patient? Okay, I'm seeing F, E. Lots of good diverse answers. Okay, looks like we've got a fair split between D, E, and F. All right, so I'm kind of hearing an echo.
Dr. Meyer, maybe can you turn the volume down on your phone possibly?
Actually just exit out of my phone. So let's see. Yeah. All right, I'm gonna stop. Yeah, I've gotten out of my phone, but I still hear an echo. I'm no longer logged in. Okay, I think that might have fixed it.
Edgar, another thing you could try, you could on your device, if you've got an audio output coming in, mute that so that your microphone's the only thing that's on.
All right, can y'all hear me still?
We can.
Okay, awesome. All right, I think we solved the issue. Okay, so we had a split between D, E, and F. So if we think of our most proximal structure, intraperitoneal, that is a part of our actual GI tract, the correct answer should be stomach. And so this kind of will lead us into a discussion of what we mean by intraperitoneal versus retroperitoneal. So to start that discussion, we'll need to start with defining what the peritoneum actually is. So the peritoneum is this serous membrane, also known as a mesothelium, which lines our abdominopelvic cavity. And if we look at the etymology of this term, peritoneum comes from the Greek peri, which means around, kanein, the verb which means to stretch. So you can kind of think of the peritoneum as a membrane that forms a sac. And if you imagine a balloon, kind of envisioned by this pink region here, inflating inside of your abdominopelvic cavity, as that balloon inflates, parts of it are going to touch the body wall, and parts are also going to touch the visceral organs inside the abdominopelvic cavity. So that layer that is lining that body wall of our abdominopelvic cavity we refer to as our parietal peritoneum. Parietal comes from the Latin word for wall, so it is aptly named. And then that portion of that inflated sac that touches our organs or our viscera. Viscera is the Latin word for internal organs. We refer to as visceral peritoneum. And so y'all have already been exploring some synonymous terms, right, with things like pericardium, pleura, just as an example. My computer is doing something a little strange. I do apologize. All right, I'm going to try something real quick, and I'm going to reshare my screen. Okay, all right, can y'all see this? Okay. All right, so with our visceral peritoneum, as these sheets fold on each other, they fold, and if you can imagine the folding like two sheets folding on top of each other, they form what is known as a mesentery. So we can see some examples of these mesenteries here and here and here as I'm tracing with my laser pointer. Again, these are those double folds of visceral peritoneum. Now, because our gut in its formation elongates and undergoes growth, we get additional looping of these tube-like structures, the small and large intestines. And because this looping and growth You can imagine that this double layer of sheet or mesentery will then fold in on itself as well. So we get a quadruple set of layers or a double layer of mesenteries. And this will create our omenta. And as an example here, we have our greater omentum. When we have these sheets folding in on themselves, they will create these potential spaces. So here in pink, we have our greater sac, okay, that larger potential space. And then here denoted by these light blue asterisks, we have our lesser sac. All right, so intraperitoneal versus retroperitoneal. All right, so our intraperitoneal organs would be those organs that are, as the name implies, inside of or encased within our visceral peritoneum. So as an example, if we look at this part of the small intestine, specifically the jejunum, we can see that this visceral peritoneum, indicated by the blue line, is completely encasing the organ, hence the name intraperitoneal. On the other hand, our retroperitoneal organs will be behind or posterior to that visceral layer of peritoneum. So you can see just posterior to or dorsal to this layer of visceral peritoneum here, we can see some structures just deep or lying behind. As an example, we have our ascending colon here on the right and our descending colon here on the left. And we have some mnemonics. So this is one that I created. So if it works for you, it works for you. Students love sharing patients' diagnostic jargon in certain treatments and signs. And you'll notice that in some of these second letters or even third letters, it's helping you keep track of what structure we're referring to in the mnemonic, as some structures might begin with the same letter. So here we have students, ST for stomach, L in love for liver, S in sharing for spleen. Patients also has a T in it to remind you that it's only the tail of the pancreas that is an intraperitoneal organ. And then there's a misspelling here, replacing the I with the number 1 in diagnostic to remind you that it is the first part of the duodenum, only the first part of the duodenum that is an intraperitoneal organ. J for jejunum, I for ileum, CE for cecum, TR for our transverse colon, and then the appendix and sigmoid colon to finish us off. So then all of the other organs that we find in our abdominal cavity would be our retroperitoneal organs. So this might be a mnemonic that many of you might be already familiar with. SAD pucker. So each of these stands for one of those retroperitoneal organs. S for suprarenal or adrenal glands, A for aorta, and then grouping together with our aorta is another vascular structure, one of the largest veins in our body, the inferior vena cava. D is for duodenum. So all the additional parts of the duodenum we refer to as retroperitoneal. The P in pucker, pancreas. So all the additional parts of the pancreas are retroperitoneal. our ureters, our ascending and descending colons, specifically, kidneys, esophagus, and rectum. In parentheses, I have indicated the structures which are referred to as secondarily retroperitoneal. And as examples, we have our ascending colon and descending colon. These secondary retroperitoneal structures are structures that are only partially covered by visceral peritoneum. So the visceral peritoneum touches part of their surfaces, but does not completely encase them, as we would see in intraperitoneal organs. At the same time, these structures are not completely behind the peritoneum with other structures or types of connective tissue, as an example, separating them from the visceral peritoneum. And so I'm using this analogy to kind of bring home this point. So our visceral peritoneum is to an organ mesothelium or organ covering, as is a tarpaulin or waterproof covering that you might use to cover a car or a set of structures that you don't want to get wet in the rain. So in this particular image here, we can see that these regions appear to be completely encased or covered by our tarpaulin. So these would be examples of intraperitoneal organs. Whereas here, we see that the tarpaulin is only covering part of a surface of this structure because it can't completely wrap around it. This would be a secondarily retroperitoneal organ. So now moving into a different case here, we're going to expand our case earlier that we were looking at, which involved the hiatal or diaphragmatic hernia. So here we have a patient, the same patient who refuses to undergo corrective procedures for her hernia. An additional 6 years pass by, her symptoms worsen, and her GI specialist performs an endoscopy procedure confirming a diagnosis of GERD, or gastroesophageal reflux disease. A biopsy from the luminal lining, or the lining of the distal esophagus that is lining the esophagus's lumen, reveals signs of what is known as metaplasia. Okay, this is just a fancy word where tissues begin transforming and start to look like tissues of other organs, so tissues that do not belong in that organ. And in this case, the metaplasia is causing the tissue to resemble the lining of the stomach. So the question is, what is the classification of the tissue lining the lumen of the stomach? And if you can, feel free to speak out loud, as I can no longer see the chat.
So Dr. Meyer, it looks like in the chat, the answers are really coming in kind of between E, which is the simple columnar, and looks like H, so stratified.
Okay, awesome. All right, so it looks like the answers that we're getting are a nice 50-50 of the two tissues that are juxtaposed with each other in this situation. So the lining of the stomach is actually going to be a simple columnar epithelial tissue. So if we look at a region where we see stomach tissue and esophageal tissue side by side, we're going to look specifically at our gastroesophageal junction, also known as the cardioesophageal junction. And so for those of you here analyzing this histological image, which is which? So we have one section here indicated by the blue bracket, one section here indicated by our black bracket. Which would be the stomach and which would be the distal esophagus?
Looks like most of the students are correct. So they're saying blue is the stomach because it's simple columnar, and black is the esophagus because it's stratified.
Okay, awesome. Great. All right, so our blue bracket, of course, is indicating our cardiac region of our stomach, given the simple columnar epithelium that we can see here, lined by these mucus secreting cells. And then our black bracket is indicating our stratified squamous epithelial tissue. Now, is it keratinized or non-keratinized?
And most students are saying it's non-keratinized, so that's good.
Okay, awesome. And that would be correct, yes. So this would be non-keratinized or non-cornified stratified squamous epithelial tissue. And we'll talk about why in just a moment. Just as a little FYI, transition zones are areas in the body where we see juxtaposed two distinct different tissue types that show an abrupt change between one type of tissue lining and another. And oftentimes, these are common sites for cancer development. And so that will become a topic of further study if you all decide to pursue careers in the health sciences.
So Dr. Meyer, I'm sorry, this is Dr. Peterson. We're right at 8 o'clock. Here's what I'm going to suggest. I know you have a few more slides, and I know that it's really important for those students that are preparing for the regional competition to get this information. Can I ask a huge favor of you? Would you be willing, after I turn off this recording, would you be just willing to go on Zoom in your own home and just record a narration for the final slides that you have, and just send that to me? And then we will post that along with this recording so that the students get all the information for all of the slides.
Yeah, I'm happy to do that. Yeah.
Okay. All right. Well, thank you. I appreciate that. I did want to say we so appreciated you being with us, and I love the way that you structured this with the cases and and your sense of humor, and I think you made it very, very memorable. So looking forward to getting that second video recording from you, and we'll make sure that all the students have access to them. So have a great evening, everyone. And again, we'll see you not next weekend, but the following weekend. So take care.